There was considerable, not disagreement, but discussion on what was the right answer for him.
Thanks. Sometimes a heart is so broken that the only cure is to replace it.
So we're heading to the pre-op area now. This is where you'll be meeting a nurse and anesthesiologist, and they'll explain exactly what's going on. Okay.
In a few hours, William Burke will have a new heart. William is 16 years old. A year and a half ago, he had just started 9th grade when doctors discovered an infection in a heart valve.
At first, when I went into the hospital, I presented flu-like symptoms, so I didn't really know how sick I was. And pretty quickly from there, I got really worse.
No one knew that William was born with an abnormal aortic valve.
He had a bicuspid aortic valve, which is a 2-leaflet instead of 3-leaflet valve that nobody knew about because you couldn't really hear it and nobody had had any reason to diagnose it. Nobody else in the family has one.
Nobody knows for sure how the infection started, although it may have happened during dental work.
The valve itself ended up getting infected, which is one of the risks of those valves, even if they function normally. Blood flow is abnormal across them, and that gives a nice ripe spot for bacteria that happen to be in the bloodstream to land on it and grow. You have a heart murmur, did you know?
It's a surprise to me.
William's infection destroyed the valve and penetrated the tissues around the heart. Valve replacement surgery at Seattle Children's Hospital was initially successful, but William had a heart attack a few months later, followed by an infection on his new artificial valve. His surgeon at Children's referred him to UW-Medicine Regional Heart Center for the second surgery.
In that location in the center of his heart, there are a number of critical tissues, including the valve itself and the apparatus underneath it, which is in close proximity to other critical structures like the atrium or the conduction system or the left ventricle. So reconstructing the core of his heart can be a technical challenge.
In all, William had 3 surgeries in 18 months. Each procedure was more complex than the last. When he became ill for the 4th time, William's doctors discussed transplantation.
So considerable decision was made by his medical team, led by Dr. Karen Stout, our transplant team, led by Dr. Fishbein, and our surgical team, who deal with these patients requiring transplantation, to pursue a different approach. We ultimately made the decision to keep him in the hospital, to treat him medically initially, and then to commit him to a transplantation.
And what procedure are you going for today? I'll start asking the questions while I'm looking. Cool, congratulations.
We finally decided to move towards a transplant as the best means of both saving his life and giving him a good quality of life in a situation where there really were no other good surgical options at all.
It's a good heart, 19-year-old. So.
William has been at the University of Washington Medical Center for several weeks waiting for a transplant. For him, the hardest part was accepting the need to replace his own heart.
He was sad and angry, but once he understood that Karen felt this was the right way to go and that Dr. Verrier was certain that this was what to do, then he was fine. He had, I think, one of the most important things for William in this process has been his belief and his confidence in his doctors.
You've been here before? Yeah. Okay. When you commit anybody to a transplant, you commit them to a different set of medical issues related to chronic immunosuppression, so you have to take medicines all of your life. Changes in self-image, when you commit that to a 16-year-old boy, that is a formidable challenge to him and to his family and to his entire support system.
Today, thanks to a young donor in Oregon, the waiting is over. It's transplant day. While a procurement team flies in with the new heart, the surgical team prepares William to receive it.
Anesthesia needed to do their job. There were a number of ancillary physicians in the room at that time, including Dr. Stout, including the infectious disease person who had been taking care of him, including my team, at least 2 perfusionists, a number of anesthesiologists, and our nursing staff, as well as knowing that his whole family was sitting outside the door, and obviously very anxious.
Timing is critical. William's old heart has to be removed before the new heart loses its viability. On the other hand, the actual removal can't begin until the new heart is in the operating room and has been medically cleared by the surgeon.
What you do not want to happen is the patient is not ready when the heart is already here in a cool box. And so we try and stage manage it and get the patient here sufficiently early and adjust whatever is necessary to suit the surgery and put all the monitoring lines in and give them immunosuppressant drugs, make sure everything is teed up.
Because of William's previous surgeries, the preparation is a little more complex than most.
If nobody's had their chest opened before, we know that in 30 to 45 minutes we can open the chest and prepare to remove that organ. But in somebody like William, it actually took us almost 2 hours to do that. And that's where the judgment of the surgeon is to coordinate, saying, I don't want this heart to show up 2 hours and before. I want it to arrive at the time when I'm ready to remove the heart. And that's a challenge.
Yeah.
The donor heart arrives.
Gentlemen. Nice job, man.
The team prepares to stop William's own heart. A heart-lung machine will reroute his blood flow, bypassing his heart during the operation.
Okay, so let's go on bypassing.
Okay, we're going on, Pop.
We're almost at the aorta.
Okay.
All right, William, it's time to get ready for this old one and get you a new one, buddy.
The old heart is surgically detached and lifted out.
Come on, heart, give it up. Okay. Oh, mackerel.
The condition of William's heart confirmed that transplantation at this time was the right choice.
This is the repair. You can see the valve looks perfect in there. Yeah, we did, and you can see how pretty that repair looked. I mean, actually.
And it healed nice.
Yeah, but if you feel his heart, this is like just hard as a rock. It was rewarding to us when we looked at the specimen of his old heart with our pathologist to realize that it's unlikely we would have ever cured his infection. So that the decision making to commit him to transplant, as difficult as it was the right decision. And so that was a tremendous relief to all of us. Is this heart ready to go over here? Yeah, it's already out.
And William has a healthy new heart. It takes about half an hour to be surgically attached, connecting it to the blood vessels and allowing blood to flow through it.
Now, put a clamp over here, 2 clamps. Ready? Pop off for a sec.
Pop off.
Clamp over here. Another clamp. Any scissor. Okay. Back on.
Back on.
That's beautiful.
Soon the heart warms up and starts beating on its own.
That whole process of watching a heart that was stopped, brought in, put back in, started back up again is an incredibly cool kind of thing to watch. I saw it when I was a third-year med student and was completely enthralled by the whole process. So just kind of watch them when they start back up. It's an amazing phenomenon. You can take a heart out of one person, put it in another, and it just starts doing what it does. It just starts beating.
3.
You ready to get weighed and for me to get your temperature? Okay.
Jim O'Donnell is waiting for his own miracle. At 62, Jim's had 2 heart surgeries, a coronary balloon to open up a blocked coronary artery, and an implanted pacemaker with a defibrillator to prevent cardiac arrest. He has 25 separate prescriptions for daily medication, which his wife Cheryl organizes for him.
I've been having a lot of trouble with my heart and a lot of heart failure. I got congestive heart failure. And so my doctor sent me to the University of Washington to be evaluated for a possible heart transplant.
Do you want to do your walk now or your questionnaires now?
The questionnaires.
The patients who we refer for transplant have what we call advanced heart disease, most commonly advanced congestive heart failure. We evaluate whether there are therapies that might improve their heart function. They could include medical therapies or electrical device therapies or cardiac surgery. And if they've already undergone those therapies or don't have those therapies as an option, we then think about what their prognosis is with that kind of heart disease. And if their prognosis is bad and they have significantly limiting symptoms, we then think seriously about cardiac transplantation.
You ready for the goo?
Jim has reached that point, and that's why he's here. The heart transplant program at UW Medicine Regional Heart Center has one of the highest success rates in the nation.
96? That's pretty good for you.
I think that the University of Washington Medical Center is uniquely positioned to offer this type of service, and we've been doing this for a couple of decades, so we have a lot of experience with this. This is not something that you do without a lot of experience. It takes the technology and the wherewithal to really do the appropriate evaluation both of the donor and the recipient.
Any problems with your equipment?
No.
No alarms or anything?
No, everything's fine.
All right. All done. Do you want to just stay on this for now so you don't use your battery power?
Yeah.
The most severely ill patients, like Jim, have the highest status on the transplant list.
There's a regional and national approach to organ transplantation. And the United States is divided up into different regions, and those regions are responsible for the organs that might be available within that region. So someone is identified as a potential donor, and then there's the list is perused from the different institutions who offer that particular expertise, and depending on how sick the patient is, where the organ is located, etc., decisions are made with response to trying to match up the organ donor with the recipient.
All right, go.
Patients may wait years for a new heart, depending on an individual's condition. Their illness may be managed medically during that time. In Jim's case, medicine wasn't enough. He and his doctors chose to implant a left ventricular assist device, or LVAD.
It became pretty obvious to my family and I that my heart was kind of deteriorating fast. And I came in for a heart, and they don't have a heart. I know I have to carry this unit around with me, but after a while it doesn't become very cumbersome. You know, it's a pretty good little system.
Jim is using his LVAD as a bridge to transplant. It was surgically implanted 2 weeks ago.
This part goes into the heart, into the left ventricle, which is the main pumping chamber of the heart. The blood comes in here, comes across here, and it's spun by this little rotor in here out to this side, which is connected up to the aorta. So this now becomes the person's left ventricle, or their main pumping chamber, to send blood throughout their body.
A cable runs from the system controller through Jim's skin to connect to the implant. The cord's special covering actually helps the skin to grow closed around the opening, which prevents infection. Jim's Velcro belt keeps the cord in place.
Well, the only thing that's really showing is this wire, and you can kind of hide that up into sweaters and stuff like that.
This is the patient's system controller. This is basically the computer piece of the LVAD. It provides them with an alarm for how much power they have while they're on battery. It tells them if there's a problem with the pump. It reminds them to change their batteries. So there's hearts and battery symbols and things that they have to learn before I let them leave the hospital.
Jim carries a spare battery at all times. Loss of power would place him in a critical situation.
This is huge. This is a large part of your life. I mean, it's a commitment 24/7. It's just huge. And then when you start opening up the book and you realize that you are ultimately responsible for making sure that his power sources gets charged, changed, and protected 24 hours a day. And when you add all of the other caretaking, the meds, the sleep, the showers, the bathroom, it's a lot. How you doing there?
In these first few weeks after his surgery, Jim isn't strong enough to do much for himself, and he needs a caregiver available at all times. If he needs emergency medical care, Cheryl makes certain the EMTs know that Jim doesn't have a pulse, since the LVAD is pumping blood instead of his heart. As more patients use the device, Shauna Andrus works to educate emergency medical service teams throughout Western Washington.
I gave them the overview of how this works, and they were like astonished. They said, well, how do we make our assessment on our patients when you're telling us that they don't have a blood pressure and a pulse? And I said, well, if they're talking to you, if their color's good, I said, you actually have to go back to some basic things of how does he look, is his skin warm? I said, if they can tell you what's going on, then it's probably not critical, and if they can't, they can't. So,
for some patients, an LVAD will be implanted instead of a new heart.
There may be a size, or there may be your immunology doesn't allow the transplant, or you have some other associated disease that would not allow you to be immunosuppressed. In that situation, we sometimes use left ventricular assist devices as a, quote, destination therapy. And we have a number of people who have been treated because it's been shown that with those assist devices, they can go out and live a fairly normal life connected to a battery, but they can go out and travel and play golf and stay at home and actually live a fairly normal life.
Ultimately, the LVAD may become a long-term solution.
There's also a concept of using ventricular devices to allow the heart to heal itself or to heal itself in conjunction with other medications. And there was a recent report which showed that certain kinds of patients may actually have heart recovery with the aid of a left ventricular assist device and a combination of heart failure medications, so that over months of time the heart actually becomes stronger and one is able to explant these devices. Now, this is not standard of care yet, but it's a very exciting concept where we use left ventricular assist devices in conjunction with medications to actually allow the heart to heal itself.
You want to put that on there too?
For Jim, the LVAD will keep him alive as he waits for a new heart. His blood type is O, so he can only receive a heart from a type O donor. The hardest part of the wait, for both Jim and Cheryl, is having to relocate to Seattle from their home in eastern Washington. Transplant patients must stay within a limited travel time to the University of Washington Medical Center.
We live in Kennewick, and it's a good 4-hour drive, and I couldn't be away from the doctors that long. They called me up and said, hey, we have a heart. I'd probably never make it in time for that heart. So they told us that we couldn't live any more than about 2 hours away from the hospital. So this is very fortunate to get this place.
This place is a furnished condominium in Seattle, which is partially subsidized for transplant patients. The expense of maintaining a second home near the medical center can be difficult. Social workers on the transplant team can offer assistance in some cases.
We're in the university, and housing around here is very expensive, and people need furnished ones, not just empty space. So they are housings, but they are always expensive, and not very many people can afford that. And typically these expenses are not covered by the insurance, so they have to come up with their own money and resource to manage. So I help them to figure out what they can do and what they can afford.
There are emotional costs as well. The O'Donnell's oldest daughter, Nikki, helps out, including driving to Seattle to bring Malin to visit. But 4-year-old Tegan doesn't understand why he can't stay with his mom and dad.
I'm going to miss you.
I want to have him here, but then I don't have anybody here to watch him if something should occur, if I had to call the EMS, or, if I had to admit Jim into the hospital or something, what do I do then? I could make a huge mistake, and I can't be worrying about a 4-year-old and Jim's life.
You be a big boy, okay?
So walk down to the track, stay around the outside, please.
Oh, here comes the speedsters again.
At 58, Ron Adkins is in better shape than he was in his 30s.
Okay, let's move on to the groin stretch.
20 years ago, he was having his first heart attack. It ran in his family.
When you have heart disease, it limits your ability to do stuff, and it limits your ability to actually interact with people. And it's so debilitating. Like I could walk maybe a couple hundred feet and then I'd have to rest.
10 years and 2 more heart attacks later, Ron's cardiologist made a choice.
And he says, Ron, I can't do anything for you anymore. He says, what you need now is a heart transplant. He says, I'm going to call Dr. Fishbein at the University of Washington Medical Center and have you transferred over to him to have a heart transplant. This is a year before my transplant.
As all transplant patients do, Ron was entering a broad network of care.
I think transplants, really a model for multidisciplinary healthcare, and that we have cardiologists and surgeons and nurses and social workers and dietitians and pharmacists all involved in the care of these relatively complicated patients. And actually we make decisions about transplantation as a team.
Ron waited 2 years. Then, one Saturday morning, a transplant coordinator called.
Says, Ron, we have a heart. Said, we need you here by 1:30. And that's a picture of Bill.
Ron didn't know at the time that his heart donor was a mountain climber and marathon runner named Bill. A car accident had left him brain dead, but his heart was undamaged.
He was very athletic. He loved to be outdoors. He was a hiker, he was a mountain climber, he loved to fish. His main passion, though, was running.
Months before the accident, Bill and his partner Flo had talked about organ donation. She knew what he wanted her to do.
The thing that I appreciate about it is that it was something that's talked about before. I think it's just like anything in a human's life that we need to be talking about these things. We need to be sharing it with our families, other people who might be present for things like this, so where that our wishes were followed.
After his transplant, Ron became an active community volunteer. He participates in Team Transplant at the University of Washington Medical Center, walking half marathons to promote organ donation. One day, while working at a Team Transplant booth, he met Flo and her daughter.
Kind of by accident, but it was probably meant to be. We met at the walk and talk, and they figured out in a matter of minutes that they had something very special in common.
When they realized their connection, it was quite an emotional moment.
From that point on, we've been in contact with each other. We keep in contact. Watching this man with his family, his grandchildren, and the person we loved would love it to be that way, because that was the whole idea behind being a donor. And what a gift we as a family have received.
It was very rewarding and fulfilling and emotional, and that was just such a huge thing. I here your loved one is laying there dying, and you have to make a choice whether you want them to be donate their organs. That's a huge deal.
That person is no longer here, and you have a part of their body in you that's helping you live. I will always consider it a miracle.
Your blood pressure's 112, 120, 117, not under 100, and your heart rate is pretty consistently under 100, 110, and you have no fever. That's good. Okay.
A heart transplant is the beginning of a long-term relationship between patients and their doctors. It involves a mutual commitment to staying healthy.
Our patients are at risk of complications after the procedure. They're at risk of rejecting the new heart. They're at risk of infection because of the immunosuppressive medications that they're on. But by and large, even though they're at risk of those problems, they do well, and they have good long-term survivals.
All right, we're in a good spot here. We'll take some biopsies.
There are medications to take and many appointments to keep. Today, William undergoes a heart biopsy to check for signs of rejection.
This is the very best way of finding trouble before it becomes trouble, in real easy early stages, and then you can adjust medications accordingly. We usually take somewhere between 3 and 5, depending on what size they are.
These biopsies are frequent in the weeks following surgery, eventually tapering off to once or twice a year. William has a few other adjustments to make as well.
I need to be careful about getting sick on the off chance that I get some kind of like pneumonia or something. But as time goes on, that becomes less and less of a problem because I'm being immunosuppressed less and less.
I think he'll be just fine. I think he might need to choose a university in a major metropolitan area that has a transplant program somewhere nearby. Other than that, I don't see anything that's going to be a major concern or a restriction in his life.
There are risks to transplanting a heart, but the rewards are great. And even for those who've seen it over and over, there are few things more exciting.
I've done this for 20 years, and I still think it's a little bit of a miracle that you can take a heart out of a brain-dead patient, put it in a sterile container, travel in the Northwest, surgically implant it in a patient with advanced heart disease, and it works. And there are some nights that I still wonder about the fact that this procedure actually is as successful as it is. Yeah, it is actually very exciting.
For more information, a consultation, or to make an appointment, contact UW Medicine Regional Heart Center, www.uwheartcenter.org, 206-598-4300. For referring physicians, 1-866-UW-HEART.